My name is Maeve Nolan, and I've just retired after 20 years working as a clinical psychologist on the spinal programme at the National Rehabilitation Hospital in Dublin.
Hi, my name is Michelle Cahill, and I'm quadriplegic. I didn't retire, but I was catapulted into retirement on the 18th of May 2018. And I worked as a consultant psychiatrist. Funnily enough, my last post was in rehabilitation psychiatry for people with severe mental illness. And I'm now speaking to you as a person who's in that process of recovery and rehabilitation following an accident in May 2018, which has left me quadriplegic. So I hope you find it helpful and insightful.
Remind me, Michelle, it's a C4 level of injury?
C4, yes.
C4. Okay. Right, I'm going to give a very brief introduction and then we're going to chat to Michelle and then we'll see how it goes after that. My main question from the time I started work in the NRH, particularly with my background in psychotherapy, is what is it really like to have a spinal cord injury? And maybe more selfishly, what would I be like if I had a spinal cord injury? And how can I support people with spinal cord injury if I don't have a clue what it's like? Michelle will tell me, I don't have a clue, and she's right. But I think it's lived experience of people who do have a clue that helps us to be with people in rehabilitation. I think that our understanding of what people are going through is what underpins all of our efforts after empathy and understanding. For example, I remember very naively at the first ESPA conference in Stoke Mandeville when I had just started working in spinal injury, and the discussion was about independence, and I rather naively said, but how can you be independent if you've had a cervical injury? And I always remember Peter Luda's quiet response, you have to learn to be independently dependent. And I have used that phrase and that concept many times over the years, and it's pearls of wisdom like that I think help us in our efforts to understand what might be going on. I think too that lived experience guides us as practitioners. We need to begin to know what it's like to be looked after by us lot. We need to begin to know what it's like to have your life altered so dramatically by spinal cord injury. And maybe for people working within rehabilitation solely, we particularly need to know what it's like to live with spinal cord injury in the many years after discharge from rehabilitation. Otherwise, we're not able to be of support to people at the early stages of this transition. I can only speak to people newly injured by holding on to a vision that I've got from talking to people like Michelle and many, many other people with spinal cord injury. I can only hold on to a vision of a different future ahead down the road for people that I'm talking to. One of the reasons I'm talking to Michelle today for our ESPA conference is that she is very much an insider to the healthcare world. As she says, working as a psychiatrist and a psychotherapist in the healthcare system has brought its own challenges over the years, I'm sure. And over the years in NRH, there's been a sprinkling of healthcare workers admitted to the spinal programme. And I know that we learn something from every patient that we talk to. But I think talking to healthcare workers, because of their insider experience to the healthcare world, I think it gives us particular insights into what it might actually be like. We learn something from every patient, but I think when we talk to somebody who's worked in healthcare where there might be a shared background or the possibility of a common language, can really help to add to our learning about the experience. For example, does the insider experience of healthcare, does it help or compound things, or does it even matter? I've always been interested in what happens when theoretical understanding meets lived experience. And just a couple of examples before we start chatting. A psychotherapy colleague was admitted to the spinal unit years ago, and she used Michelle's phrase, I was catapulted into old age, when she developed a spinal tumour in her early 60s. And one of our own rehabilitation consultants developed Guillain-Barré syndrome. And we wrote a paper for a NISCUS conference using Joni Mitchell's famous phrase, I've looked at life from both sides now. And a young woman who was training to be a psychiatric nurse spoke very openly in time, not immediately, but she spoke very openly about her suicidal ideation and her suicide attempt following discharge from rehabilitation. So when the opportunity came along to talk to Michelle very robustly during rehabilitation and less often in the intervening years, we thought it might be a good idea to try and capture some of those conversations for this paper It's a bit of a tall order for a short presentation, but we're going to give it a go. Meeting Michelle evoked in me the typical response of, gosh, that could be me. And also, what is it really like for her? I wondered, for example, if being a psychiatrist and a psychotherapist helped, hindered, or even mattered when you're grappling with a C4 injury. I wondered how rehabilitation might look to a mental health professional who is so used to being on the other side of the table. And I wondered if we could learn very honestly what your experience of rehabilitation was like, you know? So the title for this paper, Holding On to Your Mind When Your Body Doesn't Work, came from yourself.
Yes.
So I think you're the best person to explain it. And maybe we'll start there and I'll throw you in at the deep end and say, how do you hang on to your mind?
I suppose when you very suddenly, like I did, lose your body, you're damn glad that you haven't lost your mind.
Right.
And I often used to think, like you, when I was dealing with patients who had lost their mind but had an able body,
right.
How it was like. And of course, now I'm in the reverse.
Yes.
I've lost my body, but I have my mind.
Right.
And that, in some way, I've no control over my body. And I've thought about this. And in fact, most of what we do with our body, we don't think about it.
No, it's all automatic.
Yeah. So, at some level, then I said, well, all I am is my mind. Anyway. So, I can't. This was after a while now, clearly.
Not the early days.
Oh, God, no. No, the early days.
We'll go back to those in a minute.
So now I say, I actually can be anywhere or do anything because my mind can allow me to. To explain that to you, I suppose people say to me, well, what are you doing today? Because I'm doing nothing. You kind of mean, that's a meaningless question. And I'm actually now a human being. I don't do things. I'm not a human doing. And we used to always talk about being a human being. And now I am just trying to be. And in that wondrous way, having said goodbye to an able body, in that way, my mind has opened channels that never would have opened before.
Right.
Because when you're busy on that treadmill of life, you don't have the luxury of sitting and being mindful and looking at life from another completely different aspect. And then at some level, it makes an awful lot of what we do really not that meaningful.
Yeah. I remember people saying that it pares your life back to really what matters, because so much of what we do, it's not so much that it doesn't matter, but when something like this happens, it can quickly become quite trivial.
Yeah, and that doesn't in any way take away the horrendous adjustment.
Right. Yeah.
And the inordinate effort, and yet it seemed effortless. I don't ever remember really making an effort, except physical effort in the physio department. Now there you have to make mechanical effort.
Right.
But my whole adjustment, I went through the phases of wanting to die, and then I'm alive. So now I'm living in this world where I can smell the roses, I can do my life or be my life
Mm.
in a way that's very rich. And as somebody said in Buddhism, the butterfly that flaps the wings in the Sahara can affect the rest of the world. And we wonder sometimes what our role is in life. And I think just being is enough.
It's good that you say that, because actually, if I was asked to summarize the theme of what I want to talk about in this paper, it's about being and not doing. We must do, and we'll talk about that later, we must do lots of things as psychologists in rehab, but we must also learn to be with the distress that's caused. So can I bring you back to that early distress of what was it like 5 years ago when you realised this was not going to go away?
Oh gosh. When I knew from early on, really, that this was it, and I'm now my body is just there, doing nothing. There were two aspects. One was very frightening. It was really very frightening, because you actually had no control over your body now. All of your functions were now back to just kind of your basal ganglia. You had no executive control. You couldn't decide when to pee. You couldn't decide when to do anything. So your body just worked. And that was terribly frightening. And I touched my body, because my sensation was very damaged. I didn't know what part of my body I was touching. And I remember asking a nurse, and she said, "Michelle, you're touching your breast." I said, "Oh my God." And that was hard to get around, very hard. And
so there was no feedback from anything.
There was no feedback. And at that stage, I cried. I bargained with God or the universe. But then I said, I gave myself the choice that, Michelle, because having worked as a psychiatrist, and this is where I suppose my own work helped me. If I was a carpenter, it might be something else.
Right.
But in my way, I thought, I have choices here.
Right.
And I can live or I can die. And I've the choice to die. I can go to Dignitas. And that somehow freed me. Because then I said, no, I'm not doing that. I actually got quite frightened by the idea that I'd want to die, because I was a woman who was full of life and zest. And the fear of losing that was actually worse than the fear of losing my body.
Right.
Feeling that my appetite for life and my ability to enjoy hadn't gone.
Right. Yeah.
But I was grieving.
Yeah, for sure. Dublin is a very small place, and some of us in the department would have been aware of Michelle through other channels. I didn't know you personally, but it was always about being vivacious, glamorous, a skier, an active person, a socializer. So very, very much a doer. So yes, for sure, it was a massive change.
It was horrendous. It is horrendous. Does it get easier? What gets easier is actually, for me, that I'm beginning, my memory of who I was in the able body has faded.
Okay.
Interestingly.
Right.
What I initially, was in the initial 12 months, I'd say, I could vividly remember everything about myself. And I get flashbacks, and the flashbacks after trauma are very difficult. and not too many people. I don't think I was ever asked about a flashback.
Right. Flashback to a healthier self or flashbacks to the early days?
Flashbacks to my healthier self.
Okay.
Not really. Yes, I had, obviously, in my nightmares, they were horrendous too. But, and there are things that were really difficult. Even, I've lost my train of thought, sorry. So, yeah, the whole adjustment.
You were talking about actually losing, and it's interesting because at another time you would have said to me, you have to, and even in my own research, continuity of self is so important, but you talk about saying goodbye to your old self.
That's exactly what I was about to say.
Yeah.
That in that area of remembering myself, I had to say, it's like you're holding on with a death clasp. And gradually, you can no longer hold on.
Right.
So you just let go and say, no, that Michelle is gone. And I use the very controversial word of reincarnation, in that, and somehow this is me being reincarnated into a different body.
Okay.
And I say a different world. In some ways, yes. I sometimes felt I was kind of launched into a world of, we call it disability, but a world of where you were looking around, you're experiencing, and it's a whole learning experience again. So I found myself in what I would never have thought, in a situation where I was exploring the world in a different way and seeing things in a very different way, but not only seeing them, experiencing them, and I had time to. And the big question of my life then was, what use am I?
Right.
Where do I fit? I'd always been, as you said, a healthcare professional. So that was my identity.
Yes.
That was very much like I was a mother and a doctor. And like my sons had grown up and were catapulted in a way into an adult independent life by me. And then I'm no longer in that role. And how do I accept help from you as a therapist and the doctors and healthcare professionals? And that's where you have to, that overworld acceptance, but also become humble and just be that person who's able to accept help and not reject it. Because the first tendency is to go away.
Right.
Leave me alone.
Leave me alone. Yeah.
I don't need you. What do you mean?
And you're somebody who in your professional life would have valued help hugely. You were providing it. And now suddenly, if you're talking about the effort you had to make to accept help, I'm wondering what it's like for other people who think, as we all do, we're independent adults. We don't need help. And then suddenly you do.
In my time in rehabilitation, I think the help that you get physically, like your scheduled help for physio, OT, speech and language, and all of those very important aspects, because the C4 is just, your whole functioning of your body, from swallowing down to even trying to hold your neck again.
Yeah.
And in that, the real transition in your mind isn't really given much time. And so you're trying to do, and you're in a busy ward, people are busy around you. And when you come back to the being, I think it really is important that there's somebody in the team who's a psychologist, a therapist, whatever you might want to call yourself, but somebody who's willing to be with you and hear, and without naming it as a mental health problem.
Sure.
But just to acknowledge that this is a trauma.
Yeah.
This is not a mental health problem.
Yeah.
This is trauma. There's such a thing as post-traumatic stress disorder, which is much bandied around now. I don't think I ever heard that word once when I was in rehabilitation.
No.
And that's not a criticism. It's just, I don't know that I ever, in a lecture or anywhere, and yet I'm sure that everybody was. I can't be the only person.
It's interesting because I would have, written the plan for the lectures, and it's about the bowel and the bladder and the skin and the, the supports available and post-discharge, but it's not about the trauma, except incidentally. So yeah, that's an interesting thing to hear. How do we focus on that? And yet I know, Michelle, there will be many, many people who want to talk about anything except the trauma. So I think it's about sensing who you're with, and that comes back again to the being with.
I don't think I would even want to have talked about it. I'm like, all I wanted were my hands to work again.
Yes.
I didn't give a feck about anything else.
Really.
Yeah. However, in the end of the day, that's what really pulls you back. If your mind is not right, as I said earlier, then everything else collapses underneath. Your brain is who you are. Your mind. If you lose your mind, and I don't mean lose your mind in a psychotic way, but if in some way through the trauma, the neural pathways are now all flashing without your permission again. Things are happening in your brain, and they must also set up new neural pathways.
Right.
And if they're not knitted together in some way, and I think in some ways, if somebody was to come to me and say, well, how's the injury affecting you? I'd probably get annoyed.
Right. You mean when you were in rehab or now? When you were in rehab?
Or when I was in rehab.
Yeah.
I wouldn't have been, I'd feel like saying, how do you think? But I think if somebody came up and actually said it to me in the same way as a physiotherapist would say, well, look, your tone here is high, or you need to loosen up this, or you need to flex that. And if you would say to somebody, well, look, you're due to the trauma, your brain has been also affected, and your neural pathways have been affected. And it's like, you have to look at the traffic in your brain and what lights are on and which lights are off. And in some way, rather than making it into a kind of because I don't think most people would understand the whole adjustment and making choices. I don't mean to make myself different, but I think because I have already worked in the mental health, and also because I'm truly embedded in the whole psychotherapy part of work.
Sure.
That I'm more mindful of my mind.
Right. Yes. 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 And that's what I wanted to ask you. What are the kind of concepts from your life as a psychotherapist, as a psychiatrist, that really came to life as our own consultant said, looking at life from two sides? So you would have used these concepts with your own patients over the years, and now suddenly you're needing to apply them very personally. What kind of concepts helped, or what kind of concepts would you say, do you know, I thought that would be helpful, but wasn't helpful at all?
Yeah, that's a very real question, and probably a very difficult one, because, as I said earlier, when I was, for all those years, as you have been in rehabilitation, I was in psychiatry, and I wondered, did I really understand them? You know? And I think from my own perspective now, that I now feel that I have this, and I would have said to patients, you have to live with this. You can't abandon this. This is here. Now, some things you've got to say goodbye to, and other things you need to see, well, is there anything here that's positive? In a terrible question to give to somebody like me, who's a C4, who's trapped in a wheelchair, can't feed myself. How could there be anything positive? And yet, as time goes on, I have found that I'm embracing my world in a much more colourful way, in that I'm seeing things. Now, having said that, I acknowledge my age, and I'm not sure how that would be for somebody at 25. But at 25, there's a loss, but also there's a whole journey ahead. It's a new journey.
Yeah.
So I've left that highway. I'm on now to a completely different country. And I have to learn the language, and I have to explore the roads, and some will be cul-de-sacs.
Sure. And as they are, I suppose, for all of us, but in a different way. Just before we finish, Michelle, I've often used, again, Peter Luda's concept of the airbag effect, the something that comes that you didn't even know was there, that comes to support you in a time of trauma. So when I met you first, there would have been quite a lot of talk about dignitas and, that's what I'm going to do. And that's not there now. As you say, it's consciously not there. So what is it that has, that's a very big question, I know, but what is it that has made that transition from, no, my life is worthwhile, my life is valuable? You said to me, you listen, you hear, you know, we share lots of things. We have a psychotherapy background. You have two adult children. I have two adult children. So we've talked about being moms and being parents of adult children. And you were talking about hearing them and being there for them to talk to and with, almost in a, I won't say better now, that would be presumptuous, but in a different way.
Yes, and I think that word different is very helpful.
Right.
Because it's neither good nor bad.
Yes.
But thinking makes it so.
Yes.
As we say.
Indeed. Yeah.
However, what helped me? I'm sure you've heard of Man's Search for Reason, written by Viktor Frankl, who was in the concentration camp.
Man's Search for Meaning, yes. I do.
Sorry,
yeah.
And he came out and he survived, but lost everything around him. And in some ways, I think in every person that there is a resilience. And be it an airbag or be it I would say it's really being able to, this may sound awful, but being able to kind of like yourself,
Right.
you know.
Right.
I hate the word self-esteem because I say, who is that or what is it?
Yeah.
But look, Michelle, you're worth something. Make this worthwhile for you. And then everybody, you don't have to do anything, because just being there, you can be like the world, or like the natural world. The tree that stands there gives shade, does nothing.
Yeah.
Okay.
Yeah.
Nothing is permanent, and as you grow into this new person or body, well then you can explore the newness of that life. And once you leave the other life behind, my able-bodied, I think that's a crucial recovery.
Yeah.
Because if you look back, you can't move forward.
Yes. So it's the letting go of something.
Well, it's not. It's just that awful word of saying, I said before, Michelle, just say goodbye to her. And then you're still Michelle. And everyone said, you're the same Michelle. And I'd smile knowingly and say nothing. Because if you go to the beach and you look at the sea, it looks the same. But we know it has changed fundamentally.
Yeah.
And so had I.
Yes. Yeah.
So how did I? Why don't other people? That's a question that's probably bigger than I can answer.
Okay. I think that's a very good place to leave it. Michelle, thank you so much for sharing your thoughts with us again. It's not easy to do that. I know you always say, no, I'll do it, I'll be fine. But it is, with our conversations over these months, you've shared a lot of things and you've talked about how you feel. And I really appreciate that, because I learn every time you say things differently, even the very simple way you said there a minute ago. I had to learn to like myself differently. That's a very simple concept, and I think it's one that's useful.
Well, all I can say, Maeve, is thank you very much. I met you in a very different place, and I can assure you, without your help and the help of the team in the NOH, I really, and it's not to value one before the other.
No.
However, I do think that a huge part of my recovery has to come from the head first.
Yeah.
It really is a matter of mind over matter.
Yeah. And for this conference, mind over body. So thank you all. I think at the conference itself, I'll be saying a little bit more about what Michelle spoke so tellingly about there, the being, not doing. As psychologists, we have to do an awful lot of things, and they're all extremely valuable. But we also have to learn to be with the sort of helplessness that an injury like yours evokes, the sort of fear of, what can I say, what can I do? Certainly as a younger therapist, I wanted to do and to have my say and be able to be part of that multidisciplinary team. And I couldn't report on measurements of a house or of a wheelchair or of, dynamic balance or whatever it is. And I think, what do I say? So just that confidence, I suppose, to be different kinds of psychologists with different kind of people. And certainly somebody as reflective as yourself is kind of was easy to be with, So thank you.
Thank you, Maeve.